Okay, so we're going to do a quick overview on prostatic artery embolization. Probably our fastest growing procedure and the fastest growing procedure for IR throughout the country, really throughout the world. And so we'll talk a little bit about the anatomy, what we're trying to accomplish, how it stacks up with other procedures, the side effects, the equipment, and the nursing end. And we'll try to cover all that in maybe 10 or 12 minutes here, okay? So we'll jump in. So prostatic artery embolization, it's important to know basically what we're trying to accomplish. And the whole goal of the procedure is to alleviate urinary symptoms. And so what we mean by urinary symptoms is shown in this diagram. And so this is the basic anatomy of how urine leaves the male body. And so it's pretty simple. You've got the bladder, which is a muscular organ that has to contract in order to force urine out. You've got not shown here, a little urinary sphincter that has to relax that allows urine to leave. You've got a tube here called the urethra that is the tube that allows urine to exit the body. And then the prostate surrounds the first part of the urethra. And so somewhere around the 60 to 70 year range, depending on genetics, the prostate will enlarge at a variable rate, let's say. And in many, if not most men, by the time 60 or 70 comes around, you've got significant symptoms from the prostate enlarging. And what that looks like is this prostate, which starts off as about 40 cc's, can enlarge and be as big as 400 cc's. And so as that occurs, the prostate expands outward, but it also expands inward, and it compresses this tube that urine leaves from called the urethra. And so if we look at that, if the urethra looks like this, like a straight open tube, when you're 18 years old, by the time you hit this, let's say 60 to 70 year old range, as the prostate enlarges, it squeezes the urethra and it creates a compression and reduces the flow through the tube. And so that creates a bunch of symptoms. So the bladder has to work harder to push urine out. And so as it works harder, like any other muscle, it thickens and it becomes stronger, which inhibits its ability to relax and reduces bladder capacity to some extent. It also creates spasms, which can lead to incontinence. Men have less contraction force as the bladder, as it thickens, when it reduces, as it's eliminating urine and squeezing. It reduces contraction force right near the end, and so you end up in many situations with the inability to completely eliminate urine. And so you end up with a post-void residual of urine, and that can lead to infections and irritative symptoms. And many of these symptoms get worse at night. And so that kind of chronic irritation and retained urine can get worse at night. And it causes many of these men to get up 3, 4, 5 times a night. And that tends to be, in our experience, what brings this to attention. And so there are medications that help various aspects of this pathway, but the standard of care surgical or procedural treatment has been what's called a TURP. And that's a procedure that basically involves placing a bladed device into the urethra and removing the ingrowth of prostatic tissue. And the problem with a TURP is that it creates some pain and bleeding, erectile problems, and the larger the prostate, the higher the failure rate of TURP. And so the idea of prostatic artery embolization is to shrink the prostate, soften the gland by injecting particles into the blood supply. And as it turns out, a lot of the side effects, like incontinence from damaging that lower urinary sphincter and erectile dysfunction, don't come into play when you treat through the artery, and yet you get the same effect from reducing the size and softening the gland. And so prostatic artery embolization is a less invasive, better side effect profile option to shrink the gland and help alleviate pressure on the urethra that's caused by enlargement of the gland itself. And so again, the side effects are really the things we like the most about prostatic artery embolization. The side effects from PAE are typically mild, and they include, in about maybe, let's say, 30 to 40% of men, they'll get some significant burning when they urinate for 4 or 5 days afterwards, but that tends to be the worst of it. Other minor side effects are what we refer to as post-embolization syndrome. And that's kind of some fatigue and maybe low-grade fever that's caused from killing the tissue inside the body. And that's why we give a steroid pack for most of these patients. That tends to be worse the bigger the gland. And so that's one of the side effects that's not super common. One of the things that we talk about in terms of risk is non-target embolization, meaning some of the beads or the gel foam or the material that we put into the artery goes to a different artery and creates an injury. And that's super rare. That's why we use 3D imaging. And so that's a big part of kind of how we set the case up to prevent that as a possibility. And so overall, what I'm trying to say is side effects of PAE are rare, and that's why we like it. It also has to have, or it tends to have pretty good efficacy, meaning it works a little over 90% of the time. And so what equipment do we use in order to set the case up? Well, we'll go through kind of the basics. And so the idea of the setup here is we're doing femoral artery access because it's a shorter distance from the access into the prostatic artery as opposed to radial. From the right side, working from the right side to the left prostatic artery, we like a Cobra catheter because it takes that natural bend up and over the aortic bifurcation and into the internal iliac on the opposite side. So we're going from the right common femoral over the bifurcation and into the internal iliac. And a Cobra catheter is suited for that based on its shape. And then we use the smallest microcatheters that we have here in body IR. And those are the ProGrade Alpha and the True Select. And we usually use an angled True Select. We couple that with our standard nitinol wire like a Fathom, and that's our workhorse type setup. In terms of the ipsilateral or same side, we use a reverse curve catheter. I prefer a Sauce Omni. And again, that's easier than working from the Cobra or some other catheter. And so, so we start off with a base catheter of a Cobra and a Sauce Omni, plus typically a True Select or maybe a ProGrade Alpha. The particles that we use for this can be dropped ahead of time and mixed. We use 300 to 500 micron particles. The smaller the particle, the more they penetrate deep into the gland and create ischemia. But smaller particles, in the case of PAE, have been shown to slightly increase the complication rate without a clinical benefit. And so 300 to 500 particles are the sweet spot for the procedure in terms of risk and benefit. We also like gel foam pre-mixed ahead of time, and I like it kind of thick as far as microcatheter delivery goes. Pretty thick gel foam. So our typical setup again is femoral access, good to prep both sides, a Cobra, a Sauce Omni, a True Select, a Fathom wire, 300 to 500 micron particles, and gel foam. And all of that can be dropped ahead of time. As far as the nursing setup, the arteries are really small, and so it's helpful in all these procedures to have nitro ready. And so we like nitro down on the table. The sedation, it's preferable to have deep sedation because these are such small arteries. We rely on the roadmap to help catheterize and move. And if the patient's awake or agitated or moving, then they tend to mess up our roadmap, and that increases procedure time and difficulty. But it also increases radiation dose and contrast load, which are already kind of typically on the higher end of an angiogram for us. As far as antibiotics go, we tend to give a preventative dose of something that covers gram negatives, and that's for the procedure, but also for a week or so afterwards. And for us, that's a fluoroquinolone. We tend to give Levaquin IV, and then we give a similar 7-day course of Cipro afterwards. In terms of sending the patients home afterwards, we do Pyridium, which is like a topical agent that soothes that possible burning on urination that can occur after the procedure. We give some Norco just in case the patients run into some significant pain afterwards. We give a week of Cipro typically as an antibiotic preventative. And then to help reduce some of the inflammatory type symptoms that are created from the procedure itself, we give a Medrol dose pack and recommend starting that the following morning. So I hope that helps. good overview of PAE, what we're trying to accomplish, the anatomy, and the setup. Thanks.